Yes.
Well, good evening, everyone. Welcome to our quarterly VCSQI summer meeting. Thanks all for being with us here tonight. Thanks all for logging in via Zoom and donating some of your time this evening. We have an exciting agenda for everyone this evening with a focus on AFib, as well as discussion of latest updates from our VCSQI committees. First, we just wanted to go over some quick ground rules. Everybody knows how to use Zoom, I think, at this point. Just in case you don't, the little chat bar, toolbar at the bottom with the participants and chat feature can be used to interact. We pride ourselves by having an open meeting. So we encourage everybody to unmute yourselves, to chime in with your questions. Use the chat box if you'd like as well, but please, we'd like an open meeting. We'd like to have discussion and dialogue, so don't be shy. Again, just a little example here. There will be CME credits offered this evening as well. So right now we are automatically recording everybody's attendance who is in our room, and we will follow up with the details of the CMEs after the meeting. All you have to do is complete an evaluation afterwards, and then you can claim those credits. So again, tonight's agenda will start with Dr. Shor and highlights from the board. We'll move into our VCSQI committees, work groups, and partners. I'll then give a brief update from our clinical registries. And at that point, we will focus on AFib with Drs. Atwater and Sarin from Inova tonight. So Dr. Shor, I'll pass it over to you first for an update from the board.
Great. Thank you very much, everyone, for being here this evening. Hopefully, we'll be moving towards in-person meetings as we as a country and a Commonwealth get COVID under better control. I did want to start by just saying that there are storms that are expected, so we would not be surprised if we lose power. If you do, just bear with us, or we'll bear with you. The board met a couple items. We will be reviewing some of the data from the work groups, but from an overview, the AKI will be moving towards providing some recommendations. The shock group is acquiring survey data, and we'll have a future proposal and more to present at the next meeting. And the disparities work group is also working towards early stages in getting information. I did want to update a couple items from the cath film review. We have started the pilot centers with the Maryland review, and so far things are going well. We hope to present at the next meeting more data, and that should hopefully be very revealing. One of the other items is the collaborative with VHAC on the STEMI registries, trying to synergize between ACC's NCDR and AHA's Get With the Guidelines. We talked about the different options. We're having a little bit of issues with AHA allowing access, and so we are moving towards using ARMIS as the repository and making progress, and hopefully we'll be able to have more data at the next meeting, but we will be presenting, Eddie will be presenting some of the preliminary data with this project. The TBT, where it's been a slow process, but we have an email announcing that they're releasing some of the guideline recommendation data point stuff, and hopefully I am cautiously optimistic as we move forward, and certainly by the next meeting, we'll be able to present further. Lastly, this has been a strange year for all of us. From a financial and fiscal responsibility, we, as you know, have tried to be flexible and move with the times. Some of our expenses are less because we're meeting remotely, and our fiscally remain quite sound moving forward. So We continue to meet our goals and objectives from that standpoint in order for us to be able to meet the mission of VCSQI. That is a brief overview. I've given back a few minutes. Any questions from anybody, anyone else on the board that want to add additional context or updates? I don't see any questions either. So Eddie, I guess you can move ahead.
Very good. Thanks, Dr. Shor. And one piece we wanted to highlight on the healthcare disparities work group is that we have a survey in development. Sherry, would you like to tell us more about our new task force for addressing healthcare disparities?
Sure will. Good evening, everyone. Hope all is well. So we have a fabulous work group that we are developing, and it's called the Healthcare Disparities Work Group. The champions of this work group is Dr. David Wyatt from Carillion, Dr. Ramesh Singh from Inova, and as well as David Reich from Inova. We met with the group a few weeks ago to develop this survey. This survey was designed just to kind of get a consensus and an assessment of what practices, education, things of that nature that is taking place within your healthcare centers to combat healthcare inequities. So if you wouldn't mind, the survey will go out tomorrow. There's about 15 to 20 questions, depending on how you respond. Your input is very valuable. And also one of the questions that is included in the survey, for those of you who are interested in helping us move this forward, one of the questions asks if you're interested in joining this fabulous work group. However, if you don't take the survey, but you're interested in joining the survey, joining the work group, please don't hesitate to contact Eddie or myself via email or give us a call. We'll be happy to have you. That is all that I have, Eddie.
Thank you so much, Sherry. And that is a nice segue into our VCSQI committee's work groups and partners. So first up, we have Mike Brown, the Chief Perfusionist at Mary Washington, who will give an update from our AKI committee.
Hi, everybody. Hoping that I'll be able to finish this meeting out. We're getting some ugly weather. I hear it rumbling outside my house right now. So hopefully I'll keep my connection here for at least the next couple minutes. So our AKI work group is, we originally were anticipating the STS consensus statement for AKI, and that originally was supposed to be released in the first or second quarter of 21, but we're finding out that that is actually going to probably be released at best in the third quarter, probably early fourth quarter of 21. So we want to move forward. And I have a rough draft that I can show you guys. I really don't want to go through line item, but we're looking at this from a preoperative, intraoperative, and a postoperative perspective, looking at what the evidence is currently in cardiac surgery, looking at a lot of the peer-reviewed journals, and also getting some feedback from Dr. Lobdell at one of our previous meetings, about what he recognized that was on the consensus statement, as I believe he is on that committee. Go ahead, Eddie, if you want to. So pre-surgical, we're really looking at a couple of, what the standard practices are, but trying to reinforce those. DCing nephrotoxic meds, so the ACE inhibitors, NSAIDs, and metformin within 48 hours. Also looking at the feasibility of risk stratifying these patients for renal failure preoperatively. There's a strong recommendation for intra-aortic balloon pump for all high-risk cardiac surgery cases. Post-catheterization hydration protocol. There's probably going to be a fairly strong debate about that as we move forward looking at that. There's some strong evidence of doing an LVEDP guided hydration algorithm that has had pretty strong results as far as reducing AKI or the extent of it after cath and cardiac surgery. And then establishing a post-cath criteria for renal consult on those patients who bump their creatinine and what would be that trigger. Go ahead, Ed. And then from a intraoperative standpoint, breaking them out into anesthesia and perfusion goals, there's some strong evidence out there. I don't know if this will be in the consensus statement, but in the anesthesia cardiovascular journals looking at pre-induction mean blood pressures and systolic blood pressures and trying to maintain those pressures within 10% and minimizing those area under the curve with respect to mean and systolic blood pressure. There's been a direct correlation with AKI and lower blood pressure on cardiopulmonary bypass. At the same time, there is some suggestion of reducing the use of vasoactive support on cardiopulmonary bypass and leaning more towards, and I know about more than 60% of perfusionists across the country are using DO2 as their guide for therapy. There's a study that, or a goal-directed protocol that Johns Hopkins created that looked at DO2 among other factors and was able to directly link that with AKI. And so there's some value in adding that to the protocol. There's also, with less significant impacts, avoidance of hyperglycemia and glucose variability during the peri-intra-op stay. And then obviously the association with red blood cell transfusion. The perfusion goals, I think there's a lot of opportunity there. There's some literature out there supporting removing or reducing mannitol in the prime or during cardiopulmonary bypass. I think perfusion have been working for the last 20 years at trying to minimize the circuit and prime and operating volume. Doing the retrograde autologous prime with some limitations. Sorry guys, my cat just jumped up here, so I can't tell if you can see me or not, but she's with me now. She's not a perfusionist. But looking at retrograde autologous priming and some direction as to what is too excessive and where should we put our limit at with respect to total circuit volume. And then obviously the discussion about DO2, and there's some different literature out there about where that number sits, but in general, I know that Hopkins adopted greater than 300 as their target. And then again, limiting use of vasoactives on bypass. Ultrafiltration, recent study that was in Journal of Cardiovascular Anesthesia, looking at ultrafiltration. There have obviously been other studies in the past 5 years that have associated ultrafiltration during cardiopulmonary bypass with AKI. And there was a recent study in the Journal of Cardiovascular Anesthesia that actually came up with a number of finite number that those patients that were ultrafiltrated, greater than 32 milliliters per kilo actually had AKI. So there was a direct association with that. Zero balance ultrafiltration seems to be reasonable. And there are obviously going to be some exceptions, patients in acute heart failure, your mitral valve patients, but in general, limiting it to processing. Hold on one second. Come on, girl. That's what it's like with a pandemic. But there is some, there is some support with just ultrafiltrating that remaining pump blood after coming off cardiopulmonary bypass. There's strong support for that. And then also avoiding excessive rewarming. And I will tell you, the interesting thing about this and looking at the literature out there is many of these factors are also very supportive of reducing intraoperative CVA, stroke. And so I feel like there's a lot of opportunity, not just with AKI, but also with permanent stroke. Okay, Eddie. And then last but not least, postoperative management, and optimization of hemodynamics and volume status. Obviously, that's your critical care and your critical care physicians and nursing staff. Early recognition of AKI, so making sure, and I'm sure most programs do have a scheduled BUN creatinine, close monitoring of urine output, continued Foley care for accurate urine collection. Those are all pretty much standards that we're doing now, but if you're not, that's something we need to adopt. And then consulting nephrology for pre-existing AKI or post-op AKI. And what are those triggers where we get them and back involved or involved. Holding PO and IV diuresis until post-op day 2. There's some strong evidence for that. Again, avoiding NSAIDs. And then restarting those nephrotoxic meds when creatinine returns back to baseline, typically within 48 to 72 hours. Those would be your ACE inhibitors, metformin. And there also, we also got some feedback from one of the cardiothoracic surgeons at UVA talking about PPIs and their association with AKI. So we need to look at that a little bit further as well. And then last but not least is looking at the biomarker monitoring. There's some strong evidence out there in the literature for postoperative biomarker assays and predicting AKI, as well as the non-invasive monitoring that is out there. We're looking at our hospital at the Hemisphere that's made by Edwards Life Sciences that uses artificial intelligence to predict hypotension within 10 minutes before it even occurs. It has algorithms for volume and vasoactive and inotropic therapy. It gives you indexes for contractility, for vasoconstriction, vasodilation, as well as volume. And so gives you a lot of information to support your critical care team with respect to how you optimize hemodynamics in those patients. So, and I know there's some studies out there with the PICO and the FlowTrack. Hemisphere is relatively new, but it does have what's called Acumen sensor, and that is really next level intelligence for these types of monitors. So our next steps really are, go ahead, Eddie. Our next step really is to establish a consistent meeting. It's a challenge for me. It's a challenge, I think, for everybody. We're all pretty busy. So I really want to do is establish a consistent day or 2 days a month where at least we can get ahead of this over the course of the next 6 to 8 weeks. I really would love to have a cardiovascular surgery co-chair with Dr. Deemer. And then just refine this draft so that we can narrow down those those key initiatives that we want to get out there first, and then begin to to make a more comprehensive protocol. Any questions anybody has?
Thanks for the presentation. That was great.
You bet. You bet. Exciting, exciting to be a part of this. And again, we just need to be able to establish a consistent monthly meeting. And I do believe Sherry is working on sending out a survey to find out when that would be. I know Centera got an email that Centera's got a ton of people that are really interested in being involved, and some physicians from UVA as well. And so I think in the better part of Valor, we probably will have this meeting later in the afternoon so that we can get everybody involved, especially those physician champions. So that's my goal ultimately.
Two quick questions. One
Sure.
is those patients that go from cath to surgery.
Mm-hmm.
Is there a special look at those? And number two is, are you applying the pre-surgical kinds of treatments to the pre-PCI cath treatments? Has that come up in the work group as well?
It's come up a little bit, but not a lot. And I think that the reason why is we do have a stronger presence of cardiac surgery folks on the committee than cardiology. And that's where my weakness is. You know, I don't have a real strong cardiology, so to speak, background. And I think that's where we need the input, because ideally, this really is an opportunity for us having cardiology and cardiac surgery together to kind of make a synergistic protocol. We've never had that since the inception of VCSQI. And so if there, in addition to Dr. Demmer, if there are physicians or clinicians who want to take that aspect of the protocol on and run with it, I'm very much open to that. I know Chris is as well. If you're on the call, open to your additional comments as well. But yes, this really, in all honesty, Dr. Shor, right now, this protocol is kind of driven as patients going from cath to, cath to cabbage. And I think that ideally, it really should be encompass just those patients that are going to have a heart cath and maybe intervention, and not just to benefit cardiac surgery patients.
And we may want to get, as has been mentioned before, nephrology. So
Yeah.
I don't know if Dr. Damer has someone he works closely with that would be a synergistic kind of thing where we can get another nephrologist perhaps to get involved.
Sure. And I know that the COAP group in Michigan, as they've chimed in, and I think they're interested in partnering with us. Maybe they have something as well, a resource as well that they can provide to support us. So, yeah.
Hey, Mike. Yeah, this is Chris. I'm on, and I support everything you say, and I'm very excited actually about this endeavor.
Yeah, it's much needed, especially for us. So we're excited about it.
Great.
Very good. Dr. Lobdell had some items that he added in the chat box as well. And actually, he is our next update to give an update on Perfect Care. Dr. Lobdell, do you just want to give a 30-second summary of your AKI comments as well?
Certainly. Eddie, can you hear me okay?
Yes, sir.
Terrific. Yeah, thanks to you and Sherry for gluing us all together. It's been a big task, particularly in the environment that we've been discussing. But what I was thinking about as Michael was presenting that was, one, it's a lot of work, and the group's really to be applauded for organizing it. I think that the thoughtful approach of phase of care is vital to this, so that you can break it up into who does what, right, in a very organized sort of way. And the other that I would say, having participated, say, in the STS, AMSEC, SCA process to try to develop the guidelines, like always, they're very slow, they're controversial, there's the potential that there's bias, that sort of thing. And this effort is sort of cut through that and put together a great list of what I would position as considerations or standard practice routines. And that's a good way so that teams, wherever they may be at this point, can latch on to it and use what's useful. But sort of next level for the collaborative and improvement networks that we're working on things like this would be to figure out how to track those items so that we can figure out really what's making a difference. Because we've all seen guidelines, either sit on a shelf or be slow to be implemented. This is a real opportunity to take this great work, track vital things, learn and improve together. With that, I would answer any questions or segue into our brief improvement network update if you want.
Thanks, Kevin. This is Alan. I appreciate your comments. The one thing I would throw out to the committee to track is within the surgical literature, the correlation with the postoperative acute kidney injury in those populations of patients that have had a cath within 5 days. And so it'd be good to track those and to assess whether or not that is continuing to be the case with the changes in the improvements in the cath regimens, particularly with hydration and more aggressive diuretics and less diload. So this information is probably years old, and it'd be nice to update that to see if that's still the case.
Dr. Lobdell, would you like to go ahead and give your update from the Perfect Care and VCSQI collaboration?
Absolutely. Thanks, Eddie, Sherry, certainly Alan and Robert for all the great work you've done over the years supporting us through this process of building this network that we are. I think we've made a lot of progress, and we'll share that right now. So Eddie, next slide. This is the most brief of updates. I know we talked, I think it was back in March, but we, as of early May, had 430 patients enrolled between 2 of our 3 facilities. We're averaging about 30 patients a month during that time. And we think that 40 is where we'll be now with Wake Med joining. We think we'll probably be somewhere in the 650 to 700 cases by the end of the year. We've had a little bit of just operational challenge getting this up and running in our 3rd atrium facility, now known as Cabarrus. And it's always related to, COVID and staffing issues, which I'm sure everybody else is facing. But again, the great news is Wake Med's on board. They're doing that. And our next targets are Wake Forest and Navicent, all part of the atrium family. We've had ongoing discussions with ERAS Cardiac and how that integrates with this. It's obviously a bunch of aggressive, intelligent leaders like you've put together over the last 20 some years, but maybe a real opportunity for things like AKI to define goal-directed therapy or how we want to approach AKI and some of these other things in more granular detail than we have at the SDS database, and track it and correlate it with our outcomes. Some of those same conversations that Eddie's been a part of, and we've talked intermittently with folks up in Maryland, and I'd like to see that progress. In other words, we all come together. We're working on various analyses of the data, presentations, publications, and then I think the near future is a closer look at our teammates. So things like trust, teamwork with a colleague that's in the leadership space as an academic in business schools, also with WHOOP and Arena Labs. And then we're also working with some folks that are very advanced in implementation or instructional system design, a company named Learn to Win. So, it's one thing to provide guidelines. It's another thing to actually train people and implement and then track how well they're doing. This group, Learn to Win, has done some incredible work with the military, professional athletes, sports teams, that sort of thing. So we're pretty excited. Next slide. Here's that, say, more recent look of coronary only, which is always easier to look at a homogeneous group, but 120 coronaries in that Perfect Care group. And as you can see, we've done well with respect to death and complications. It's noteworthy that readmissions are less than 50% of benchmark. For what it's worth, from our raw data, not vetted and all, that continues, in the same thing with the improvement in length of stay, whether it's post-operative mean, median, or total length of stay. Total length of stay is even a little better. As I was thinking about that today, I was trying to figure out why. There's always the potential there's a bias, but we're trying to uncover all of that as we analyze this. Next slide, Eddie. Purposely blurred this out a little bit, but we're in the process using Power BI to do some financial analyses. Eddie and the crew here knows as well as anybody, there's looking at real cost, and then there's looking at benchmark data. But for what it's worth, it would appear sort of the most conservative estimates that we've made so far. If we take benchmark data for the cost of a hospital day and or cost of readmission and just compare risk stratified groups like low, medium, high with all the patients that we've done, it looks like we'd save somewhere in the area of $3,000 a case. And you guys know your cost better than we do maybe, but that would appear that the most conservative estimate is that's about 8% of what we're reimbursed on average per cardiac case. The potential is significantly higher than that, but I think that's where the conversation starts. So we're just trying to look a little bit more at that. And it's really pretty remarkable. One, that we have the competence to do this work. Two, that we have great clinical results. And three, it looks like the financial impact has been quite significant. Next slide. Future summary, I think that we're expanding, both the volume of patients as well as the number of facilities as we collaborate. So that helps with the proof of concept and the volume. We'll have to see how clinical results continue, but certainly in our centers, there's been no change whatsoever. In other words, it's continued success now, close to 2 years. July is 2 clinical years, and we have another 6 months to go with the grant. Again, the analysis with financial impact. And then I think the near future, as I alluded, is finding technology partners. And interestingly, the number of calls has just increased exponentially over the last couple of weeks. I think as we're exiting COVID, people have learned to do some of this remote care. They're thinking more about data management and so forth. But I've had conversations with Verily, Medela, Abiomed, and to try to piece all that together, what I think it says is if we piece together this network that we've talked about and we have rich data and we can track what we're doing, it's really a treasure trove for those that want to learn and improve. And I think that there's going to be a lot of technology partners that will look to us, even smaller numbers and pilots because of the experience, because of the data management analytics to help us learn and improve. So I think it's really encouraging. With that, I'll pause and hand off, Eddie.
Kevin, thank you for this update and all the diligent work over this time. For those of you that don't know, Kevin, in spite of being the head of critical care and research for Atrium's cardiac group, is now a lieutenant colonel in the Army and has been on and off active duty during this past year. So kudos and congratulations. The question regarding Wake and the others that you're looking, will they follow the same paradigm with the technology, both with the remote monitoring and the watches and the iPad access, some of those things that we discussed before? Is that still the sort of spine of your perfect health, perfect care model?
Yes, Alan, and thank you. It's certainly my pleasure to serve, but the answer is yes on the remote monitoring. We're in the middle of our talks with Carium with the idea that we want to solidify the plan for 2022 to make sure we have continuity. Simultaneously, we're in the ongoing discussions with ARMIS, which you guys are most familiar with, in trying to solidify 2022. And then, like all technology and evolution, I think what we think about as a network is what's the best way to do this in the future, sequence our partnerships and efforts and so forth. And I say that because I think data management, analytics, risk modeling are vital to doing this work, as well as that clinician-patient interface. And for any of us to project what that looks like, 3 and 5 years down the line is pretty difficult. But the things that excite me is the fact that we've been able to do this, that we have growing interest. And I think that as we all come together over these things, we'll figure out collectively what's the best way to do it. And much like the standard practice routines with AKI, I think we should also build in the ability to have multiple approaches to doing the work. In other words, once we get this going, you know, it could be Seamless MD, it could be Vox Telehealth, it could be Carium. It's less important whose platform, as long as we can manage the information and learn from it.
Thank you. And I guess my last question, and you may have touched on this, is that with the big shift during the pandemic to Zoom, has that been a significant part of this, as well as the weights and all those other things?
If I'm hearing the question correctly, it certainly helped us with proof of concept. There were a lot of people within the organization that were interested in doing it. At the same time, there were probably some challenges too, that people are trying to get to scale right in their efforts. So it becomes a system problem. And then you kind of get swept into, you know, prioritization of interests and efforts. If we were more nimble as a small, you know, study, and suddenly you've got the whole organization say they want to do it, you can see sort of the balance and all of that. But all the work that we're doing, I think, has been recognized. What we're really trying to do is tell the story as well as we can. If anybody's got ideas or angles of how to look at this in different ways, we're open to that. I think that's some of the real potential as we come together, you know, is not only replicating the effort, but how do we look at it? How do we tell the story to garner sort of more support from our technology partners and others? Because I think that's how we ultimately all, again, learn and improve together.
Thanks, Kevin.
Yeah.
Very good. Thank you very much, Dr. Lobdell.
Thank you.
I want to keep us moving forward with an update from our VCSQI clinical registries. So first up, we wanted to start with a polling question just to draw out the interest from the group. And based on a lot of the good things we've heard from the team thus far, what initiative or work group are you most excited in thus far? Choices are AKI, shock, perfect care, diversity and inclusion, the STEMI registry, which we'll touch on in a minute, or other. And looks like votes are coming in here. We've got about 17, 18 in. We'll give it another 5 seconds, 10 seconds here. All right. So it looks like AKI is the winner here. So Mike, you're going to be on the spot, but there's interest in basically every topic. The STEMI registry is also of interest. That's our number 2 vote getter, but it looks like everything is on people's agenda and radar screen. So I just wanted to take a quick test of people's interest in what they've heard thus far. So let's look at some data. We briefly mentioned the statewide STEMI database in Dr. Shor's update. This is a quick look at just what the overall model will look like, where we're taking it individual hospital uploads from both the major STEMI databases across the nation, and then ARMIS will aggregate and report on those metrics for us. So that's kind of the high level overview and how the data will flow. But the overall goal is to marry, again, the 2 data sources back to a statewide STEMI registry like we had with ACTION several years ago. So this is where we are thus far. We have right now 17 centers have signed their database agreements with ARMIS. We're in the process of figuring out how to get all the data together, but we do have 11 centers on board and aggregated in the registry at this point. So this is our first stab at a scorecard for Q1 to Q4 calendar year 2020 with the 5 main metrics that Dr. O'Brien and the team at VHAC had prioritized as far as the most meaningful and impactful STEMI metrics. So median door in, door out time for transfer patients, median transfer time between hospitals, first medical contact to primary PCI, less than 90 minutes for non-transfer patients, median FMC to primary PCI, and then the percentage of cases with pre-hospital EKGs. And we've shown the VCSQI average across these 11 centers, as well as color-coded green to orange based on a hospital's performance. So this is, again, a first-level start at our statewide STEMI push. And just wanted to give a teaser. These are the same hospital codes we use for Cath PCI. So if you know your code, that should be consistent between the two sets of reports. But we're eager for your feedback and really excited to get this new database off the ground. Questions, comments, anybody who voted for STEMI? Do you have any thoughts on these?
I think this has been a lot more work than we anticipated, but I really think we are getting close to the finish line, and kudos to Pete and Mike and to all the folks that have been involved in this, of course, with Eddie and Sherry. So this is very exciting.
And you can see there's over 2,000 patients just in calendar year 2020 alone. We will have historical data going back as well. So there's already a pretty significant impact or potential for impact here. In the interest of time, we'll keep moving forward, but we'll share these with everyone on the call afterwards as well, just to start getting some ideas turning on the STEMI reports. Next, we'll take a quick look at our Cath PCI data. These, again, are calendar year 2020 reports. They're grouped by program volume like you've seen in the past. Let's dive in. First, we're looking at the overall volume by month for total PCI cases, as well as STEMI volume. You see the big dip in April of 20, of course, with the COVID lockdown. Overall, there was about a 10% drop in PCI cases in 2020 and a 7% drop in STEMI. Most of that, I think, would be attributed to April, but still it seems like there's a little bit of a lag to come back to full capacity. So we'll see how that kind of continues to shape up. So as for our volumes, this is data by hospital showing vascular access site, radial versus femoral. So we continue to see an increase in the proportion of radial cases, but still wide variation. There are some certain centers, especially in the higher volume, that are using close to 50% or more of their cases via the femoral approach. So it's an item we wanted to keep our eyes on as we continue to see better outcomes for radial patients in general. Please stop me with any comments, questions. Next is risk-adjusted bleeding for PCI without CABG. The overall VCSQI average here was actually pretty low, an OE of less than 1. We just wanted to show this as an overall quality indicator for the VCSQI Cath PCI programs. Notably, 5 of our 7 high volume centers are below that 1.0 average here. Next is a look at discharge time. We've talked about the proportion of same-day discharge for elective patients. That number continues to increase slightly over time. We're at about 31% same-day discharge across all VCSQI programs. 10% are overnight within 24 hours, and a little under 60% are discharged over 24 hours for elective PCI cases. This look again shows the disparity between hospitals and an opportunity to standardize practice, I believe. Like certain centers are doing more than half of their patients same day for elective cases.
Eddie, hi. Does this include both elective PCI done radially and elective PCI done femorally?
Yes, this is all elective cases. It's an interesting idea. We can break this down radial versus femoral too.
At our last meeting, I think you had the femoral and radial broken down. So tying that to the discharge time would be good.
Do that. This next chart does just that, where we show AKI rates for femoral versus radial approaches. Again, we know there is a difference in terms of the risk profiles, with femoral patients being higher risk, but regardless, we're still seeing significantly higher AKI rates in that femoral group, which is a piece that Dr. Damer, the co-chair of the AKI work group, and I are looking at right now too. So more to come on these, but these are our cath PCI metrics and areas of focus that tie in with a number of our work groups and initiatives as well. Next is a quick look at our STS reports. These again are calendar year 2020. We're comparing some prior 2 years of data against the last 4 quarters worth of data as well, just for a little bit of context. First, we have a look at volumes. Again, we saw a big dip in Q2 of 2020. Overall, about a 20% decrease in open heart cases for calendar year 20 as compared with the previous 2 years. And the biggest dent felt like it was in the CABG patients here as well. Next, we will look at some indicators by hospital. First is 30-day readmissions, which has been a focus of VCSQI in the past. In calendar year 20, we saw actually the lowest readmission rate that VCSQI has seen in a number of years. We were under 9% in total. So you'll see the blue bars for calendar year 20 as compared with the orange bars for 18, 19. Many of these centers have gone down, if you'll see those comparisons. So I don't know if it's because patients didn't want to come back due to COVID or what the reason was here, but we've seen pretty low readmission rates. Next, we have renal failure observed to expected, so risk-adjusted renal failure. VCSQI average is about 1.25 here, 1.27. So in general, programs seem to struggle in 2020 with renal failure, which underscores the need for our AKI work group and the good work that Mike and team are doing there. Next is multiple arterial conduits by hospital. This was a report that was suggested by Chris Seitzma of Winchester in terms of looking at variation in arterial grafting practices. So we looked at radial grafts, we looked at dual IMAs, and this overall is a composite for multiple arterial conduits by center. So you'll see a lot of lot of variation here. Some are not doing it at all. Others are doing it for more than half of their isolated CABG patients. Chris, did you have anything you wanted to add here?
Well, yeah, what I wanted to say is that we have a new surgeon on board, and at that time we're re-examining our practices and looking more at evidence-based practice. And what we were seeing is that the literature did suggest that more arterial conduits for revascularization is a good thing. So we were looking at our current practice with bilateral IMAs. We're about 0 on that. We do use a fair amount of radials, but nothing near what they're doing with the VCSQI or the STS. We even broke things down by age, by gender, and had some very interesting information. For example, patients over the age of 80, about 60% get radials, where if they're less than 60, we're up to 80-some% radials. So we're doing a lot of examination of arterial conduits, and I didn't know if any other team was interested in that we would share data, or if that was just something that we were going to kind of focus on this year. Okay, Andy, thanks.
Thanks, Chris. Well, we'll continue to monitor this. And next up, we can link this up against different outcomes metrics, and we can kind of, like we show for radial and femoral access, we can show that for the multiple arterial patients versus non-PAC patients too.
That was my comment. It would be nice to compare the data for complications against this length of stay, et cetera, et cetera.
Yeah, I do want to take this opportunity to thank Eddie and Sherry for all they do. I think that sometimes we forget what's done behind the scenes. And I know if I have a request, the turnaround is usually less than 24 hours. And that just blows my team out of the water. So thank you very much.
It's our pleasure, Chris. And please keep those requests coming. And then that goes for everybody out there. We're eager to make use of the database and really want it to improve the lives of patients via our state registry here.
Hey, Eddie, can you hear me?
Yes.
Hey, going back to the slide on renal failure, I don't know if you can go back to that, but when we look at this slide, is there any way that we can go back and compare this to cath date and then procedure date, surgical procedure date, and see what the correlation is? I mean, Dr. Spear had mentioned that in the chat, that he thought that would be a good start, and I agree. I know that we've kind of looked at that a little bit in some of the data that we ran a couple months ago, but just looking at that, just in looking at isolated CABG, I think that might be a good opportunity for us. And to see if there's a trend over the last 3 or 4 years, because I noticed that renal failure has become more of an issue in the last 2 or 3 years, at least for us, than years previous, and to see if there's any correlation there, and any correlation with, transfusion. I know we've looked at this, but I think it'd be great if we could take a deeper look into it. Thoughts?
Eddie, along those same lines with renal failure, can you go back to the slide for AKI for femoral versus radial? So the question that's been bouncing around in my head is, obviously with the femoral approach, you're probably doing that more on emergency patients who may be hemodynamically compromised. And maybe that might explain why your AKI is higher in the femoral approach. Robert, have you any thoughts on that?
Yeah, I mean, I think we were thinking it was the higher acuity, and hopefully the acuity indices will be able to help separate some of that out. I think Eddie had pulled some of that too.
Yeah, when we looked at risk-adjusted AKI, the rates are still significantly higher for femoral patients versus radial. So it's a publication actually Dr. Damer and I are currently looking at. We can discuss offline, but my great suggestion as well is in terms of looking at renal failure against the cath time. We can definitely do that.
And Eddie, again, you know, looking at this slide, I know this is without cabbage, but is there a way to look to see if there's an influence on that slide that you just showed, comparing radial versus femoral to if there's a correlation between that and cabbage and the cabbage population?
We would have to check that. That might be a little trickier.
Okay.
Is it possible to correlate? I mean, obviously, anybody who's getting circulatory support who's in shock is going to be having femoral access. Do we have that data also to be able to pull that subset of patients out of the femoral block?
Yes, we can pull out the pre-procedure shock if that's what you're asking.
Yeah. Okay.
Very good. Thank you. Thank you all for your suggestions. This was Mag. The last piece, and this ties into our presentation tonight, is looking at new onset of AFib by hospital. Of course, this is an initiative that VCSQI has continually looked at over the years. In 2020, we actually saw our AKI incidence decrease. We're a little bit below 23% as a state. You know, there's a lot of variation by program. Some of our best practices are generally around the 10 to 15% AFib rate, and thought this would be a good segue into our feature speakers for the evening. And with that, I will pass it over to Dr. Spear, who will introduce our two guest speakers for the evening. Dr. Spear.
Thank you and good evening. This is a real pleasure to introduce Drs. Sarin and Brett Atwater for our focused discussion on atrial fibrillation. I was struck this morning of note that on our leadership presentation for the hospital system for neurosciences, which in Inova has about 175 providers in the 5 hospitals, one of their primary focused initiatives in the coming year is stroke, but particularly stroke related to atrial fib. So I thought it was serendipitous that we're talking about this subject tonight, and it was initially to be a sort of a point and counterpoint with the surgery versus catheter ablation. But I think as you'll see, that has given sway to the collaborative and complementary treatment in these different populations. Dr. Brett Atwater is the Director of Electrophysiology and Electrophysiology Research for the Inova Heart and Vascular Institute, and we were privileged to be able to recruit him in December, this past December, from Duke. He graduated from the University of Chicago Pritzker School of Medicine and completed his internship and residency at Duke University. He completed his general cardiology fellowship at the University of Wisconsin-Madison before returning to Duke for subspecialty training in clinical cardiac electrophysiology. After completing his training, he joined the faculty at Duke as an instructor and was also the director of electrophysiology at the Durham VA Hospital. He subsequently assumed the role of director of the electrophysiology labs for Duke and was an associate professor of medicine with tenure before we were able to recruit him to our institution. He's authored over 75 publications and is the primary investigator in several active grants, and his research interests are in cardiac resynchronization therapy and atrial fibrillation. Dr. Eric Sarin is our section chief for cardiac surgery for Inova. and is a recognized authority in the treatment of mitral valvular disease and atrial fibrillation, particularly through minimally invasive approaches. He's a graduate of the University of Michigan and received his MD at George Washington University School of Medicine. He then trained in general surgery and surgical critical care at the University of Colorado, and then did his cardiothoracic training at Emory. Of notice, he received his degree in tropical medicine from the London School of Tropical Medicine and Hygiene with the Royal College of Physicians. And that, as you can anticipate, has been very helpful as a cardiac surgeon. So we're constantly asking him about mosquito bites and those types of things in the jungle that we're in healthcare delivery. But gentlemen, thank you for giving us your time and effort on this subject, and we look forward to seeing what the changes have evolved in both surgery and electrophysiology. With that, I'll open it to you both.
Thank you, Alan, for that kind introduction, and thanks everybody for the opportunity to come speak a little bit about recent changes in medical and procedural management of atrial fibrillation. Feel free to stop me along the way if you have questions. I heard you were a talkative group, so I look forward to some dialogue. There are two, I think, important points of change in the medical management of AFib I just want to make sure everybody was aware of. The first is a change in our anticoagulation guidelines, which came out with an update to the consensus statement for AFib management in 2019. And that is that we are now instructed to only anticoagulate women who have a CHA2DS2-VASc score of greater than or equal to 3, and men if they have a CHA2DS2-VASc score of greater than or equal to 2. Prior guidelines suggested we should do that for everybody with a CHA2DS2-VASc score of greater than 2. This came about as a result of realizing that the female sex characteristic that's included in the CHA2DS2-VASc score is not a very strong predictor of stroke relative to everything else that's included in there. And therefore, they pushed the value up to 3 for women. The guidelines also suggest that we should use DOAC therapies, such as Pradaxa or Eliquis or Xarelto as our preferred anticoagulant, and use warfarin only in those patients who either can't afford it or don't have access to it for some other reason. Another big change is with the use of rate control and how aggressive we should be with rate control. In 2006, the consensus statement said that we should have a goal to try to get people's heart rates down into the 60s to 80s at rest. And there was a clinical trial called the RACE-2 trial, which compared lenient strategy of resting heart rates less than 110 to a strict strategy of heart rates less than 80. And they found that the lenient strategy was non-inferior. And this was then reflected in the updated consensus guidelines, which gave strict control a class 3 indication for patients with persistent AFib and an EF greater than 40%. And that's because the strict control was associated with a higher cumulative incidence of primary outcomes of poor outcomes. So as a result, we've been a little more lenient on how aggressively we rate control people with beta blockers and calcium channel blockers since that time. Moving on to more recent data, 2020 was a big year for us in atrial fibrillation management. Among the trials that came out was the EAST-AF-NET-4 study, which was revisiting the question of whether rate control or rhythm control should be used initially for patients who have atrial fibrillation. And so what they did is they randomized 2,800 patients in a one-to-one fashion. These patients were recently diagnosed with atrial fibrillation. They had minimal or no symptoms from their AFib, but they did have a high CHA2DS2-VASc score greater than or equal to 2. If you were randomized to the rhythm control arm, you could receive either an antiarrhythmic drug or an ablation, and all patients were instructed to continue anticoagulation in both arms. That's an important difference compared to the AFFIRM trial, which we used for many, many years to make decisions about using rate versus rhythm control. In the AFFIRM trial, many patients who were assigned to rhythm control stopped their anticoagulation. We think that contributed to a higher risk of adverse events in the rhythm control arm in that study. So in this study, we asked everybody to continue the anticoagulation in both arms. The primary outcome was a composite of cardiovascular death, stroke, or hospitalization with worsening heart failure or acute coronary syndrome. And in the study, patients assigned to rate control stayed on rate control. This is in the top box that you see there. And patients who were assigned to rhythm control largely stayed in the rhythm control arm through the 2 years of follow-up. Only about 35% of people switched over to the rate control arm. So pretty good adherence with minimal crossover. These are the results of the EASAF-NET study, which showed that a rate control strategy was not as good as an early rhythm control strategy for the cumulative incidence of the primary outcome. And the hazard ratio was 0.79, with rhythm control providing improved outcomes compared to a rate control for the initial strategy of atrial fibrillation when somebody develops AFib for the first time less than a year before we see them. The subgroup analyses are over here on this forest plot, and what you can see is that the sicker the patients were, the more benefit they got from an initial rhythm control strategy. So those people with a high CHA2DS2-VASc score of greater than 4 benefited seemingly more than patients with a lower CHA2DS2-VASc score. Those people with a lower EF benefited more than the patients with a higher EF. And those patients with symptomatic heart failure seemingly did better than patients without symptomatic heart failure. So if you're a sick patient and you have atrial fibrillation, it seems that a rhythm control strategy is particularly beneficial. Most people in our field believe that this study, along with 2 other major studies that came out with randomization between rhythm and rate control, are likely to move our guidelines into a position we haven't been before, which is to recommend an initial rhythm control approach, including catheter ablation of atrial fibrillation for patients when they first present early after their AFib diagnosis. So I'll just update you a little bit about how catheter ablation is performed in 2021. Things have changed dramatically in the last 20 years with how we do catheter ablation. We use usually general anesthesia, but many centers have moved to MAC. That's because the procedure duration has really come down significantly in the last 2 to 3 years. We typically get 2 to 4 sheaths, and those are 7 to 9 French sheaths, which are placed in the femoral veins. Intracardiac ultrasound is used to guide most parts of the procedure, and as a result, many places now are using zero fluoroscopy, no radiation exposure, and no lead for anybody in the room. Some of us still use a little bit of fluoroscopy. I typically use between 2 and 5 minutes for the whole case. The procedure duration now is between 45 minutes and 3 hours. 45 minutes is pretty typical for an experienced high-volume center who's doing mostly paroxysmal atrial fibrillation. 3 hours is more characteristic for somebody who's doing a long-standing persistent atrial fibrillation where there's more work to be done. We discharge our patients the same day as the procedure in over half of cases. This dramatically shifted in 2020 as a result of COVID. Many of our patients decided they did not want to have a procedure if they had to stay overnight in the hospital. And as a result, we did a lot of work to be able to assure the safety of same-day discharge. We've done that successfully. Our success rates for paroxysmal AFib range between 70 and 80%, depending on which study you're looking at. Persistent AFib is usually in the 60% range, and then long-standing persistent, which is defined as having AFib uninterrupted for greater than or equal to a year. The success rate with catheter ablation in that population is lower at about 50%. Complication rates are somewhere between 2 and 6%, depending on which study you look at and what they define as a complication. Our procedure endpoint for paroxysmal atrial fibrillation really hasn't changed much in the last 10 years. We look to get entrance blocks. These images on the top are electroanatomical maps, which we create for every patient who's getting a radiofrequency ablation. Voltage is identified by color. So purple is normal voltage, red is no voltage. You can see these are the 4 pulmonary veins coming out of the atrium. And as the vein exits and gets closer to the lung, you lose the voltage as the muscle sleeve disappears. This patient has some scarring in the left atrium, and you can identify that by areas of low voltage there. After ablation, you can see that inside the rings of ablation that we create, there's no more voltage. That's entrance block. So electricity is no longer able to get through the line of ablation and activate those veins. We also look for exit block, and this is a case I did earlier this week. This is my catheter in the right superior pulmonary vein. This is the line of ablation that was created. You can see that the catheter that's in the right superior pulmonary vein is fibrillating, and the coronary sinus is in sinus rhythm. So the atrium is in sinus while the vein is still in fibrillation as we isolate it. This is a really nice endpoint that we don't always see, but we do always check for exit block on every case. For long-standing persistent atrial fibrillation, the endpoints are a little bit more difficult, the procedure endpoints are a little bit more difficult to understand. And that's because we've struggled to improve the success rate of these procedures over the many years that we've been doing it. Cath ablation, which is continuous fractionated atrial electrograms, which you can see on these images, If we ablate areas that have these complex fractionated electrograms, we can, in some studies, improve AFib-free survival, although that has not been consistently shown across studies. Additional linear ablations, for example, roof lines, mitral distance lines, in some studies have suggested an improvement in outcomes, although that wasn't true in a randomized controlled trial called STAR-AF. Recently, we've moved to doing a lot of posterior wall isolation. This is shown in this image where in the beginning of the case, the patient has normal voltage. Then after isolation of the posterior wall, there's no more voltage in the posterior wall. We were excited that by reducing the total amount of substrate available for atrial fibrillation to operate in, we may be able to improve outcomes. However, the most recent data suggests that there is not a difference in outcome between posterior wall isolation and PVI alone. And we're still waiting on randomized controlled trials to really evaluate this more carefully. Meanwhile, people are continuing to evolve, and we're doing left atrial appendage isolation, posterior wall isolation in combination with additional linear ablations. And so in persistent and long-standing persistent AFib, we're still searching for a good solution for how to handle these patients. Posterior wall isolation has some challenges, and there are opportunities for improvement. We are excited about doing ablation of the posterior wall because it shares embryology with the pulmonary veins. They originate from the same location, and we frequently observe AFib originating from the posterior wall. We have frequently also identified that the posterior wall will remain in fibrillation after it's isolated from the remainder of the atrium, and the atrium will convert to sinus rhythm. However, only some patients that we see have an arrhythmogenic trigger located in the posterior wall. So we're looking to see if we can identify who those people are before we get them on the table so we know who needs a posterior wall isolation and who doesn't. Epicardial connections into the posterior wall can make this a difficult procedure to do. So we have a success rate of around 94%, but 5 to 6% of people simply do not have successful isolation when we attempt to do it using endocardial-only ablation. And the durability of this lesion set is questionable. I would say about 20 to 25% of patients who have acute isolation of the posterior wall end up reconnecting it at some point when we do endocardial-only ablation. There's also some concern about the proximity of the posterior wall of the esophagus and maybe a higher risk of esophageal damage by doing posterior wall isolation. We currently use two energy sources for ablation: cryoballoon, which freezes the tissue, and radiofrequency ablation, which heats the tissue. The cryo technique is a single shot technique where we put the balloon into the pulmonary vein, turn it on, and freeze for about 3 minutes. And this has been associated with a 70 to 80% AFib-free survival. Radiofrequency ablation has a very similar outcome. This is catheter is moved in a point-by-point technique where we currently use about 30 to 45 seconds of energy at each location. This coming year, we will be reducing that to about 4 seconds at each location using a high power, short duration approach where we use 90 watts instead of the typical 35 to 40 watts. And by using 90 watts, we can get an effective lesion in a very short period of time. Pulse field ablation is coming in 2022 as well. There are 2 randomized controlled trials that are ongoing right now. Pulse field ablation is a different energy source which creates electroporation of the atrial tissue. And in 3 seconds, you can get complete isolation of a pulmonary vein with delivery of the energy. You can see that in this picture. A single 25-patient single-arm study was published in 2020. These procedures were all performed under either conscious sedation or MAC anesthesia. The skin-to-skin time was 125 minutes, including about a 30-minute mandatory waiting period. So a pretty quick procedure. They got acute pulmonary vein isolation in every single patient. They also got acute posterior wall isolation in 25 out of 25 patients in this study as well. And you can see that the lesions were durable over 82 days. So every patient came back and had their veins reanalyzed with a second invasive procedure to see how long and how well the pulse field ablation lasted. You can see the posterior wall isolation lasted in 100% of these cases. So it seemingly is a more durable energy source than either cryo or radiofrequency ablation. One patient had a complication out of the 25 that were included in the study, and that was a cardiac perforation, which was likely unrelated to the energy source. And they did do EGDs in every patient, or in 21 patients at a median of 3 days after, and they saw 0 esophageal injury with the energy source. So it seems that the energy source may be more efficacious with better long-term results and have lower risk of having peri-procedural complications. So we're excited about what this may mean for catheter-based ablation. I'm going to finish by talking about left atrial appendage occlusion. 2020 was also a big year for that for us. The Pinnacle trial was released this year or last year, which was a 400-patient study of the new Watchman FLX appendage occlusion device. This is a reiteration of the former Watchman device, which we've been implanting for several years. The study looked at 24-month follow-up. These patients all had elevated risk of stroke and bleeding. After the implantation, patients were continued on a combination of DOAC and aspirin for 45 days, and then switched over to Plavix and aspirin for 6 months. The primary safety endpoint was all-cause death, ischemic stroke, systemic embolism, or device procedure-related adverse events. And then they had an efficacy endpoint of how well did we close the appendage, and that was measured as a flow orifice of less than or equal to 5 millimeters on the side of the closure device at 12-month TEE follow-up. The results are that the device is significantly safer than the older device, with a complication rate of only 0.5%. And 100% of subjects had elimination of flow in and out of the appendage at a 12-month follow-up. They were able to safely stop the anticoagulation at 45 days in 96.2% of subjects. And there was a device-related thrombosis risk of 1.8% within the first 12 months. Many of these were in patients who had thrombosis of other structures that were put in place, including one that was a catheter ablation of atrial fibrillation, which occurred afterwards, and it was thrombosis of the ablation equipment. So in summary, we expect catheter ablation will likely be given a class 1 indication as the initial treatment strategy even before intermittent drugs for certain patients early after paroxysmal AFib onset. Pulse field ablation looks to be promising as a game changer for improved durability, improved safety, and further reducing our procedure times. Left atrial appendage occlusion appears to be an excellent alternative to DOAC therapy for management of stroke risk in patients with atrial fibrillation. There is a direct randomized controlled trial for the initial treatment strategy of either DOAC or left atrial appendage occlusion using the Watchman FLX device in an ongoing study called the Champion trial, which we're excited to see. And then finally, patients with persistent AFib continue to experience worse outcomes than patients with paroxysmal. And this is, I think, a real opportunity for us to work together with cardiac surgery, coming up with new and better ways to help take care of these patients collaboratively. Thanks, everybody.
Eric, thank you very much, Brett, and appreciate that. There's several questions that come up, but why don't we just get Eric's presentation, and if you don't mind, and then we could address questions to both of you, if that would be acceptable.
Sounds great.
Good. Dr. Sarin?
Yeah, all right, great. I'm going to try and share my screen here, so just bear with me. See if that works. Are people able to see that?
Yes.
Perfect. Okay, well, I know we're sort of running up against the time limit, so it won't take too long, but I just wanted to take the opportunity. First, thank you for the opportunity to participate tonight and be a part of it. This is something that I know, been aware of for a long time and had some involvement with it. So it's always nice to be able to kind of dip back in and be involved. When we talk about surgical treatment of atrial fibrillation, we're really talking about the life work of Jim Cox. So in cardiac surgery, in much the same way that we associate mitral valve repair with Alan Carpentier or aortic root reconstruction with Tyrone David, Dr. Cox really is synonymous with surgical treatment of arrhythmias. The first procedure he did was in the late 80s, and then over the subsequent 2 decades continued to iterate and refine the technique, both by lesion set, and then as newer technology became available, the cryoprobe technology and the radio frequency technology, he was able to integrate that in the procedure as well. So the choice of the maze pattern, the obviously 2 main objectives. Obviously, number 1 was to ablate atrial fibrillation by breaking up the various sort of triggers and drivers that are responsible for atrial fibrillation. But then obviously the second one was to leave the possibility of a sinus rhythm. And that's where the sort of eponymous name of maze came from, if you look at that figure on the bottom left of the screen. So the lesion sets over time evolved from what was the Maze 1 to then the Maze 2, where certain operative changes were made based on what they saw in the postoperative, both postoperative period and long-term outcomes of their patients. The Maze 3 was sort of the culmination of the surgical iterations, and then the Maze 4, which is what we commonly perform today, is really the Maze 3 lesion set with some modifications, but then using cryotherapy or radio frequency ablation to really help simplify the procedure and get away from the original cut and sew technique. So the Maze procedure is really beautiful in the sense, in the science that's behind it. Although the electrophysiologists live in this world every day, as cardiac surgeons, this is not something that is sort of, obviously a very comfortable space for us, which is part of the reason I think we have difficulty with kind of uptake when it comes to the procedure. But obviously, every lesion we perform has a real purpose in terms of how it's going to affect AFib. So the pulmonary vein isolation, which we've kind of the cornerstone or the basis of any procedure if you're going to do something for AFib. Adding the box lesion then gives you even more effective therapy against the triggers, starting to affect some of the drivers, completing the left-sided lesion set by creating extensions to the left atrial appendage, amputating or at least occluding the left atrial appendage at its base, and then adding a lesion to the base of the mitral annulus across the coronary sinus. Really is kind of what we consider a complete lesion set on the left side. And then moving over to the right side really is, completes the Maze procedure in terms of giving us the best chance of treating all these sources for atrial fibrillation. The current Maze 4, and I realize some people may be familiar with that, but I also know there's a lot of people that might not. So we'll just quickly kind of run through what that looks like. We start typically on the right side, mobilizing Waterston's groove so we can encircle the right side of pulmonary veins. Here you can see that's been done. Clamp is across the right at the orifice of the left atrium where the right superior pulmonary vein and inferior pulmonary vein are coming in. You can see the right pulmonary artery there to the left of the screen. Post ablation, there's that nice ablation line. It might be difficult to see, but obviously now you've isolated the right side of pulmonary veins and then non-isolated left atrium. This is where you would be able to conduct, check for conduction block, exit block, as Brett alluded to. Moving to the left side, typically this is done on bypass. I usually do it immediately after I've placed my cross clamp. Once you've kind of mobilized the heart up, start by identifying the ligament or Marshall, dividing that with electrocautery is very simple, and then that takes you very nicely into your dissection plane around the left side of pulmonary veins, which again, you can use a radio frequency clamp to create your ablation line there. Attention is then directed to the left atrial appendage. You can either decide to preserve the appendage, or just open the orifice and then occlude it at its base, or you can amputate it at its base and oversew it. Once you've opened it, though, you're creating another ablation line from inside the appendage across its base and then exiting into the left superior pulmonary vein. That's creating, basically bridging that previously created pulmonary vein isolation on that side. So in these pictures, you can see the left atrial appendage is open with the jaws of the radio frequency clamp being placed into the pulmonary vein. The left superior pulmonary vein. One nice trick why you have this exposure is to identify sort of the watershed area on the posterior wall of the heart between the right and left coronary circulation. So typically identifying the PDA and then the last obtuse marginal on the coronary sinus. In between those two spots, you can mark it with a marking pen, which will then help you identify placement for your cryoprobe when you move back to the left side. So here you can see that being done. And then obviously the last thing is to occlude the appendage either with a commercially available clip or by cutting it close to its base and then oversewing it with a prolene. The Maze proceeds then to finish the left side. Now you open up the left side of the left atrium, by Waterston's groove. When you take a look inside, typically the view you'll have, it's a little bit hard to see, I'm sure, but you can see the sucker is in the left inferior pulmonary vein. You can see the orifice of the left superior pulmonary vein and the mitral valve off in the distance. When you open up the left atrium, at this point, you've already done this much. You already have these ablation lines have been created. So your bilateral pulmonary vein isolation, the base of the appendage bridging into the left superior pulmonary vein, and then because of the surgical incision, you've already started your roof and your floor lines. These are going to be continued to completely isolate the posterior wall of the left atrium by connecting both the superior and the inferior pulmonary veins. This can be done using radiofrequency or cryothermy, depending on your preference. When I do this procedure through a minimally invasive approach, all of the left-sided lesions are done using a cryoprobe. Once you've completed your box lesion, then you're turning your attention towards the mitral annulus. And here, this is where that little mark on the coronary sinus comes back into play. You can see, and you probably can't see, but in that picture up on the left, you're identifying where that mark is on the coronary sinus, so you can place your cryoprobe across it safely and not worry about injuring one of the coronary arteries, but also be confident that you're across the coronary sinus and across the and to the mitral annulus. The cryoprobe, is necessary for this step because you're not able to get a radiofrequency clamp to go as far as you need it to go down to the mitral annulus. They talk about identifying where your ice ball is on the inside of the atrium, on the endocardium, and marking it with a marking pen, which you can see in that picture. Typically, the freeze line is pretty obvious. You don't need to mark it, but it is important because you want to make sure that when you provide when you place your endocardial lesion, that you're lining up over your epicardial lesion to make sure you have a full thickness freeze there to make sure you can complete your ablation line. And with that, you then move on to whatever left-sided operation, if you have one, or continue with the rest of your surgery. The right-sided lesion set, typically people do that when they've taken the cross clamp off while they're allowing the heart to reperfuse. When I do this minimally invasively, I typically do this first before I cross clamp because I'm usually doing it in the context of a mitral valve and then opening the left atrium on an arrested heart. On the right side, certainly through a sternotomy, but also in a minimally invasive approach, the phrenic nerve comes a little bit more into play. So you have to be a little cautious about, your radiofrequency clamp, but certainly your cryoprobe. You start with an oblique atriotomy on the right atrium, being mindful, obviously, where the sinoatrial node and the atrial pacemaker complex sit. Open that up, provides you exposure inside the right atrium. A cryoprobe is then used to create your first lesion to the tricuspid annulus, typically in the 2 o'clock portion. While this is being done, you can then proceed, and create your other lesions. You can see here the cryoprobe across the 2 o'clock portion of the tricuspid annulus. The yellow catheter there is the Swan-Ganz catheter going through the tricuspid orifice. And then after the probe comes out, you can see this nice little freeze. The radiofrequency clamp then is used, or a cryoprobe, again, based on your preference, to extend your ablation up to the superior vena cava. Here, obviously, you want to make sure that you're not impacting the sinoatrial node. And typically here is, if you're using cryo, I think you have to be particularly careful if you're placing your probe externally, because at that superiormost aspect of the ablation line, the phrenic nerve can get pretty close if you're not careful. So this is what it looks like if you're doing with the radiofrequency clamp. This is then the extension down to the inferior vena cava, again using a radiofrequency clamp. And then lastly, you're going to extend this lesion set up to the right atrium. Again, surgeon preference, whether you want to use a radiofrequency clamp as pictured or a cryoprobe. Then the atriotomy is closed. So to move quickly into just talking about some of the surgical data around this, we're going to focus on concomitant AFib. So obviously, when we're taking someone to the operating room for another reason, whether it's valve surgery, coronary surgery, and then they have a history of atrial fibrillation, there is certainly value in talking about ablation, surgical ablation for standalone AFib, but that's kind of beyond the scope of this talk tonight. So we recognize that concomitant AFib is typically due to a left-sided problem, mitral aortic valve disease or coronary disease. When we talk about the electrophysiology of it, obviously it's different than what we see in standalone AFib. So whereas that can be effective to just focus on the pulmonary veins, you're going to have a higher percentage of non-pulmonary vein triggers. So particularly where this becomes relevant, and certainly our societies have really emphasized this in the context of mitral surgery. Multiple studies have demonstrated that a significant minority of patients that come to mitral valve surgery have concomitant atrial fibrillation. This is a paper from Mark Ilanov at the Cleveland Clinic showing that the incidence of AFib in patients referred for mitral surgery increases with age, and that as multiple people have pointed out, the presence of preoperative atrial fibrillation in mitral valve patients is a negative predictor for postoperative survival as well as complications. So this is, I'm going to pivot now and just talk about some of the data we have from the VCSQI. Hunter Mahaffey actually presented this, I think, at the December meeting, and then it was just published in JTCVS in March, I believe. But looking at concomitant ablation during mitral valve operations and looking at data both from the Virginia Cardiac Surgery Quality Initiative and then also from the Michigan database, you can see that ablation, concomitant ablation over time has actually started to dip a little bit, and certainly for something that has a very strong endorsement from with societal guidelines, we could be doing better. You can see that there's obviously a pretty wide variation from center to center. This table is from that paper. It's busy, but it's great in the sense that it really shows the wide range of practices from depending on the presentation of the patient, the type of surgery performed. And so I think when we look at the operation that we have, which has been around for a long time, is based solidly in science. We have new technology in terms of the radiofrequency and cryoprobe technology that allows us to do it much easier. Why don't surgeons do atrial fibrillation surgery routinely? So historically, these are sort of the main concerns that get identified. We talk about safety. I think certainly in the era of the cut and sew maze, that was probably going to be a little more valid, but there are multiple papers now. This is one from Nevad, my predecessor here at Inova, looking at concomitant maze operations at the time of aortic valve replacement or coronary bypass surgery, and it did not increase perioperative risk or major morbidity. It's a similarly themed study from the University of Ottawa, same thing. You can add these procedures without increasing surgical risk. This is also a paper from Ralph Damiano at WashU in St. Louis, again, looking at adding a maze procedure at the time of mitral valve operations, did not affect the procedural mortality. And this is actually a very interesting paper that came from Vinay Badwar looking at STS national database data, where not only was it safe, but actually a surgical ablation at the time of surgery actually resulted in a 30-day reduction in mortality and stroke. And it's obviously a very large database study. So I think the safety concerns at this point, I think should be put to bed. People talk about the unsure of the advantages, or I just don't believe it works. But multiple papers demonstrate its ability to effectively treat atrial fibrillation and restore a normal sinus rhythm. I think that, again, multiple papers will talk about the improvement in quality of life. I don't think any of us would choose, if we had the choice of being an AFib or in sinus, we would obviously choose sinus. Another advantage is, by halting the progression of AFib, you can limit the progression of tricuspid insufficiency, and then freedom from long-term risk of stroke, which has been demonstrated in multiple papers as well. And then lastly, being in atrial fibrillation is going to affect your long-term survival. And that's something that I think, we would all recognize and, agree that on the benefits of being in a sustained sinus rhythm post-surgery. So the one other thing that in terms of kind of an obstacle is the perceived lack of consensus. I think this is a very hard argument to make since, you go back to 2012, there have been consensus statements both from the International Society of Minimally Invasive Cardiac Surgery that then was, signed on by all of these associations, recommending that patients with documented atrial fibrillation should undergo some ablation procedure at the time of open surgery. Our STS guidelines, as recently as published in 2017, especially with mitral valve surgery, give it a class 1 level A recommendation. So to put that in context, that's sort of the same as recommending mammary use at the time of CABG. And then obviously also echoing the the safety of the operative procedure. This was also similar guidelines came from the AATS, again, with a very strong recommendation for concomitant AFib surgery at the time of mitral valve operation. And I think, really so when we talk about why we have this deficit, I think really what it comes down to is a lot of people are uncomfortable with it. And I think the AATS guidelines in 2017 recognize that and offer the recommendation that when people are new to starting AFib ablation surgery, or that if they haven't had adequate training, that they are proctored by an experienced surgeon and kind of really brought up to speed, and so in a way so they can feel comfortable. And I think also part of it is going to come down to education, so people can clearly understand what the risks are of leaving atrial fibrillation untreated, the fact that the surgery itself is safe, and then also understanding what the long-term outcomes are. So, when you look forward, going down the road, where do we go from here? So this is going back again to Hunter's paper in terms of what the barriers were in implementation. This is the survey data from the surgeons, in both the VCSQI and the Michigan database who responded. And, while, 46% said there were no barriers, you look at, the yellow and the red, the next highest ones, well, 22% saying it adds additional cross-clamp time. And that may be true, but when a surgeon says they're worried about cross-clamp time, that's a surrogate for saying they're worried about safety. And there's a lot of data, obviously, to show that the operation can be done safely without increasing morbidity and mortality. I think that the smaller group there of my patients are too high risk. There's always certainly a discussion that needs to be had about whether or not a patient is appropriate for adding an ablation operation at the time of their surgery. But I think that all cardiac surgeons, we like to think that we only operate on the sickest of the sick, but I think that there's certainly room for improvement there as well. And then as you get into the smaller numbers in terms of the responses, you can really see where the opportunities for education come in, where people saying they're not very comfortable or they don't have proper equipment, they think it worsens arrhythmias or they don't think it works. And then the proposals from Hunter's paper are very much kind of what we saw in the guidelines from the 2017 AATS document. It's really around education, both around the benefits of concomitant ablation, but then also, making people feeling comfortable about asking for help in terms of being taught how to do the procedure safely. And I know that I'm running a little bit late, so I'll just kind of skip to the summary slides. I think in 2021, when you look at the body of evidence that we have, especially and the guideline support that we have, we should almost be viewing this, that we should be justifying why we don't perform a concomitant atrial fibrillation ablation operation, in the same way that we would have to justify not using a memory at the time of CABG. The solution is obviously multifactorial. It's going to require continued education of surgeons regarding the safety, the efficacy, and basically how to perform the procedure. But I think most importantly, it's really going to be a meaningful partnership with the EP providers and the general cardiology providers, and the adoption of a true heart team approach for patients with arrhythmias. And I think that's really going to be the most important step in terms of how we improve managing these patients. And thank you very much.
Thank you, Eric and Brett, for you've given everything we wanted to know about atrial fibrillation in right at about 30 minutes. And I recognize our time, but I did have a couple of questions if I could kick them off for both of you. I was struck with both, Brett, you mentioned in one of your slides on one of the studies that the procedural endpoints were not well defined. And then Eric, I think we're both cognizant that there really is no consensus on the absolute lesion sets. You showed the biatrial maze, which we of course do and are proponents of, as well as Damiano at the Cleveland Clinic with Mark Gelinov and Damiano at Washington University. But at the same time, we have an excellent group in Northwestern that just does left-sided mazes and uses cryoablation versus the combination of biatrial maze with radiofrequency and cryo. And so the lack of consensus is probably as much of a either conscious or subconscious reason to say, well, if we can't get together and understand the lesion sets, then do we know what we're talking about? And so for both of you, what's it going to take? Because there's no absence of data. There's just not. And for people to say there's not a survival stroke, left ventricular failure, tricuspid, benefit, that data is out there and has been out there since 2008. So what's it going to take to really standardize our treatment on both from the EP perspective as well as and come to consensus, particularly about how we're going to define efficacy, and then for procedurally in surgery? How are we going to figure this out?
I can start. So I think what we need to understand is what the AFib is in the patient in front of us. So Eric had a nice slide where there's a variation in the interplay between non-pulmonary vein triggers, pulmonary vein triggers, and substrate, and to know the patient has, whether the patient has non-pulmonary vein triggers before they show up in the EP lab would be helpful. So you know that you need to do non-pulmonary vein ablation in order to address those. To understand what the substrate may look like before you get in there, to know whether you need to modify the substrate with cafe ablation, for example, would be helpful. That personalized approach, I think, to persistent atrial fibrillation is what's going to lead us to improved outcomes. We just don't have the ability to understand what we need to do before we step into the EP lab or the OR. I think we don't know that until we get there. And that is a major problem for us right now. And so we're keen to just do the same thing for every patient. And that, I think, for persistent AFib is the wrong approach.
Thank you. Eric?
Yeah, so I agree with everything Brett just said. The one thing you brought up about just surgeons and kind of why we struggle, and I think we've really been our own worst enemy in the sense that there hasn't been consistency. And you look historically, you'll have someone tell you, well, this is how I do a maze. Well, it shouldn't be like that. And that's, I think part of the confusion amongst kind of the rank and file cardiac surgeons who maybe don't do a lot of it is that they feel like they hear, 20 different ways to do it. And then if you're not doing it the way Dr. Cox designed it to be done, then your results won't kind of match what we see, what we expect in terms of the literature. So I think not having delivered a consistent message over time, I think one of the most damaging things. But I think to really do it right goes back to what Brett just said, is that, when you and I take someone to the operating room to do a maze, I mean, we know, are they, whether they're, paroxysmal or not and all that other stuff, but we're doing the same lesion set every time. And so to actually have kind of a mapping, sort of going into it where we can say, look, this is really what their main problem is. And then being able to map our patients post-operatively after we've done our lesion set to make sure that, because one of the issues always with these energy sources is, are our lesions transmural? Are they really generating, kind of the effect that we think? So if we're not really objectively measuring those kind of, our patients pre and post-operatively, we're never, I think, really going to break through, because you're not going to be able to show that real benefit that we believe we get from, when the procedure's done right.
Brett, just to expand on what Eric said and also what you alluded to, we know that the French showed years ago that the origin in the paroxysmal, the primary triggers are in the left atrial or in the pulmonary veins. And so 70 to 80% of the paroxysmal triggers are at that site. So it's with good reason that you're seeing in that population the efficacy of catheter-based ablation, and now in some series with knowledgeable providers in the 70 percentile range. But then it does fall off, and the persistent and long-standing persistent, you're almost down to a coin toss at 50%. And so do you think, as we are with less invasive techniques, that if you've given them a shot at the, with the catheter-based ablation in the not the paroxysmal population, but the longer standing persistent and long-standing persistent, should they just go to a minimally invasive phase because we can provide the beneficial outcomes at approaching 90% or greater?
I think there's a reasonable argument to be made that's the right thing to do. What we've found in our studies of recurrent atrial fibrillation after ablation is that when we remap them, the majority of the patients have reconnection of at least one of the lines of ablation that we did before. Typically, you'll find at least one pulmonary vein, if not multiple pulmonary veins, that have reconnected electrically to the atrium. There are two mechanisms that this happens. One is incomplete ablation on the first go around, which is the main mechanism. These patients typically have recurrence of AFib within months of the original procedure. The second mechanism is actually that the body will send stem cells out from the bone marrow to the areas that we ablate, and on the long term, electrically reconnect pulmonary veins that we've isolated. This has been shown in patients who are bone marrow recipients from like a sister, for example, and they have found that the cells that are crossing and reconnecting contain the sister's bone marrow rather than the host's XY. And so we know that the bone marrow is capable of sending stem cells out and reconnecting pulmonary veins as a result of those studies. So durability is a major problem for us with catheter ablation techniques. That would, I think, be addressed if we did send people for a standalone surgical approach. But in many cases, what we find is that when we do a second procedure and we hit those local spots that are reconnected with better aggression or more intensity, that we can get good long-term results. So I don't know whether the field will be ready to move to a strategy like that as a whole.
Do you think that the time, and this is probably the most provocative part of this discussion, and I'll stop here, but we know that operator volumes are totally consistent with excellence of outcomes. And the number of people that are absolutely incapacitated with the antiarrhythmic drugs and stroke and the prevalence of atrial fibrillation. Do you feel like that the smaller centers should not be doing catheter-based ablation, and these should be centralized in higher volume centers with documented expertise? Or where are we moving with that?
If you're a patient who has atrial fibrillation, you want to go to a physician who does a lot of this. That's true for everything that all of us do. And I think that going to a place that doesn't do a lot of AFib is going to put yourself at risk for having higher rate of complications and lower success rate. The trouble is that high volume centers don't have a lot of capacity to increase that high volume. This procedure takes specialized equipment, which is expensive, in an EP lab, trained staff, the time of the electrophysiologist, and places that do 600 to 1,000 afibrillations a year can't double and triple the number that they're doing. It's just not possible because they've got to hire a number of additional people, and it's just very difficult. That's why all these centers are popping up and they're doing this procedure outside of these big centers. There's a ton of AFib, and the incidence is growing, and as a result, we need the help of smaller centers to do a lot of work, frankly. So I don't think that the field is likely to move in that direction. But I do think that the new technologies are going to make the procedure a lot simpler and a lot safer. And so lower volume, smaller programs are going to have better outcomes as a result of the way that the procedure is evolving.
Well, thank you both. I will open it up for any other questions. I know we're approaching the end of time here, and I'll greatly appreciate you both taking time and effort to give us this overview. It's been long overdue. And I'll open it up to any other questions from our participants.
Yeah, this is Bob. First of all, thank you guys. This was fabulous. In the past, there had been discussion of hybrid procedures, whether there's any role for wanted comments on the role for hybrid procedures moving forward, and what the crossover is between catheter-based ablation going to surgical ablation, maybe at the time of mitral valve surgery, or someone who's had a surgical ablation ending up with catheter-based procedure, what your comments were about those.
Eric, do you want to talk about hybrid?
Yeah, sure. I mean, as you know, the hybrid, the most recent data is actually, pretty compelling, and we've started our program here. I know that a lot of other institutions in Virginia have started one as well. I think this is actually going to be a very nice intermediate step. As Brett said, I think there's always going to be a little bit, and rightfully so, there's always going to be a little bit of apprehension about sending someone to surgery, going on pump, all that stuff. And so I think this, with the hybrid, the convergent procedure, you're able to do a good, ablation of the posterior left atrium, and then thoracoscopically, you can get to the ligament of Marshall, you can include the left atrial appendage. So you can do a pretty darn good job. And I think, as you were talking about, it's sort of in terms of the crossover going, from one to the other, I think that's really where instituting a real heart team, the multidisciplinary approach is going to be really critical, because then you can, decide, okay, but which path should someone go? Is a hybrid appropriate or not, or should we be thinking about surgery?
Yeah, I totally agree with that. I've highlighted how we struggle on the posterior wall with epicardial connections and reconnection across our lines. These are cases where a hybrid approach would have a superior outcome to an endocardial catheter-based approach, I'd say. So a patient who does have focal triggers on the posterior wall, I think potentially has some benefit to a hybrid approach, especially in an era where our energy sources frequently don't get transmural ablation lesions from the endocardial side. I think in terms of crossover from catheter to surgical and surgical to catheter-based techniques, ideally a center has excellence in both of those fields. And that's because that crossover will invariably occur. The holes form in lines for a lot of reasons, and having the ability to touch those up either with a surgical or catheter-based technique, having a hard team approach to that, I think is the best possible solution for the patients.
Thank you. One last question from my perspective is percutaneous left atrial appendage isolation with a Watchman versus a surgical clip. Preferences, comments. I know with the Watchman, we end up doing a TE to make sure that they are isolated. But I don't know that that's recommended for when the left atrial appendage is surgically clipped to make sure that it is truly isolated. Just throw that out there for some comments.
So yeah, with regards to surgery, I think there has been some issues in the past. I think when the early iterations of the clip, how well they held, and then there's obviously always going to be a surgeon variability in terms of really getting it down to the base. So I think there's a couple ways to do it. On an open case, I routinely just cut the appendage and then oversew it at its base. Part of that is I justify it just by I'm saving cost, but I also, having had to reoperate on some patients who've had those clips put on before, they can have pretty dense adhesions just from the reaction you get inside the pericardium. When I am doing a clip procedure, which is what I would be doing in a minimally invasive approach, I always do it, provided, obviously you get a TE first, make sure the appendage is clear. But I do it on a beating heart, on bypass without the clamp on, and then you can reposition it in real time while you're having someone check your TE to make sure that you're completely across the base and occluded. And with the newer clips now, if it's in the right spot at the time of surgery, it shouldn't move.
Do you ever do a TE to verify post closure or isolation to make sure that it's truly isolated? Or you just assume at the time of surgery, if it's good, it's good?
Yeah, so I mean, are you talking about after the day of surgery, sometime down the road to follow up?
Yeah, kind of like what we do with the Watchman. We verify that once it's healed, that there is no residual communication.
Yeah. So it's in terms of completeness, no, I'm not as complete as I should, but I know just from the, my colleagues here in the Inova system that pretty much everybody will get an echo at some point. And then, if there's ever an issue, I hear about it, but thankfully, knock on wood, most of the time I don't. So I think that, it is being confirmed certainly before someone's going to, think about taking someone off anticoagulation or something like that. But, again, you're right. I mean, if to really be, I think, a center of excellence, all the things that Brett's talking about, but having routine echo follow-up, whether it's Watchman or, a surgical clip is going to be mandatory.
Other comments? Well, this has been extraordinary. I think we've gone over a little bit, but this has certainly been worth the while. Great discussion, great team approach. Eddie, did you want to close out and have any other comments?
We thank everybody for joining us this evening. We hope we can, we can continue using data to drive these initiatives forward. So please share your ideas, share your thoughts. We hope to see everybody in the fall. We hope to not see any cicadas then, and just send our best to everybody. Thank you all for being part of our VCSQI collaborative.
Thank you all.
Good night. Thank you.